Good morning, everyone. My name is Tracy Jensen. I am one of Craig Hospital's provider relations team, and will be your moderator today. As a bit of housekeeping related to continuing education credits, we will have 3 poll questions launched throughout the webinar. So please be sure to answer all of the questions to receive credit. Technically, you really only need to answer 2 of the 3, but you must attend at least 50 minutes of the presentation to receive credit as well. Credit is being provided from our partners at CEU Institute. So you'll be receiving an email directly from them after the webinar regarding credits and any additional information for that. Credit will go to those who have signed on with the email you used to register for the presentation. If you are in a room with multiple people, each person will need to sign on individually to receive credit. Or you can also get in touch with me and I can send you a group attendee form. Providing our talk today is Craig Hospital's amazing Katie Cassady. Katie is a speech pathologist, brain injury specialist, and certified yoga therapist. She is the Craig Hospital Aphasia Therapy, also known as CHAT, program coordinator, and has been a part of the CHAT program since 2019. She graduated from the University of Michigan, majoring in psychology and linguistics, and went on to receive her master's degree in communication sciences and disorders from Northwestern University. She received her 800-hour yoga therapy certification through Inner Peace Yoga Therapy and is certified by the International Association of Yoga Therapists. Katie has been working at Craig since 2006, and her enthusiasm for working with neurologic disorders has continued to grow over the last 18 years. If you have any questions during the webinar, please feel free to submit a question in the Q&A window. I will answer your questions or try to ask questions throughout the presentation if time permits. And without further ado, I will hand things over to Katie.
Oh, sorry, got to figure out how to unmute myself. Thanks so much, Tracy, and thanks for having me. And thanks all of you for being here and for your interest in a topic that is so near and dear to my heart. Aphasia is the reason that I got into speech therapy all those years ago. Today, we'll be learning about aphasia, as you know, and you'll be learning to distinguish between the different types of aphasia. You'll consider how communication is really present in all aspects of our lives. And you'll be using case examples to discern factors involved in positive outcomes for aphasia treatment. So let's begin. I know with the population that is attending this conference or this lecture, that most of you are likely somewhat familiar with aphasia, but we will go over briefly some definitions and some specific things. Aphasia is a language disorder resulting from damage to areas of the brain that subserve production and understanding of language in various modalities. That comes from Hallowell and Chapey. It is acquired, so meaning it's acquired by individuals who have experienced normal language function at some time in their lives. Typically, it results from a stroke or from traumatic brain injury, but also may be associated with a brain tumor or progressive disorders like dementia. Essentially, acquired meaning it's not developmental. It is neurogenic, so it arises from the brain and is not related to injury to body structures. And most importantly, it really is always a problem of language. It's not the same as being forgetful. A lot of times you'll hear people with aphasia say that they forgot. It's word finding and naming and being able to come up with a word is very different than having forgotten what you want to say. So, yeah, that's an important aspect of distinguishing aphasia from something more like memory or executive functioning. When it comes to differentiating between aphasias, historically, you may have heard the terms expressive versus receptive aphasia. These are terms that speech therapists have used historically, and it's the common nomenclature. But it's actually, if you think about it, quite misleading to use these terms because by definition, in order to be diagnosed with aphasia, you have to have a confrontation naming disturbance. So really all aphasias would be considered an expressive aphasia. So I'll talk a little bit more about how these terms definitely have a place in talking about aphasia, but in terms of really helping us differentiate, these aren't the most helpful ways to do that. So we'll get rid of that. And what we're tending to use now is to distinguish between aphasias when it comes to fluency. And this is a more brain behavior based approach, using the central sulcus. You see this green line showing up here, to divide the brain into the anterior half and the posterior half. The anterior half, you can see where the motor cortex is, and that it's more related to motor output, expression, and therefore fluency. So if you're having a hard time kind of getting your muscles to do what you want them to do, also related to sort of stringing full sentences together and grammar. So we really have a difficult time being fluent. And so our non-fluent aphasias usually associated with an infarct to that somewhere in the anterior left side of the brain. Sorry, I forgot to mention left side of the brain. The classic ones that you may have heard of would be Broca's aphasia. You see Broca's area there. Transcortical motor, similar to Broca's, may be considered slightly less severe because these patients can typically repeat words, whereas people with Broca's may not be able to repeat. And then a global aphasia would be maybe somebody who has injury to both anterior and posterior, and so exhibiting symptoms of both fluent and non-fluent aphasias. But if you're exhibiting aspects of a non-fluent aphasia, then you're going to be non-fluent. Next, we'll look at what happens if the infarct is in the left side, posterior to the central sulcus, and that half is responsible for sensory input or comprehension, so the information coming in. Damage to the damage to the posterior part of the brain results in a fluent aphasia. And we'll speak to kind of that expressive versus receptive in terms of confrontation naming. Again, everyone who has a confrontation naming disturbance with these types of infarcts to the brain, that's an expressive aphasia. So to say someone has a receptive aphasia, I think it sort of leaves out the fact that they also are not, it's not one or the other, I suppose, is what I'm trying to say. Some of the classic fluent aphasias are Wernicke's, that again, we'll have some examples of these. Transcortical sensory, similar to Wernicke's, but these patients can repeat. Conduction aphasia, typically fluent, but the classic symptoms of a conduction aphasia are that they don't tend to have like a phonemic representation of words to map onto. So they often kind of know what the word begins with potentially, but they just can't get all the way through it. But their connected speech sounds relatively okay, just sort of empty. Anomic, meaning that they can't name things very well, but in conversation, you may hear them stringing sentences together appropriately, but using a lot of words like stuff and thing or device, words that aren't very meaning heavy. We won't talk a ton about subcortical aphasia, but these are the aphasias that are associated with damage to white matter tracts, not the cortex. And a lot of times these have symptoms that are consistent with, aspects of a non-fluent and also a fluent. So it just really is important for the speech therapist to do a thorough assessment and treat the symptoms, and treat the patient that they see in front of them. As kind of a cheat sheet, we'll talk about kind of we'll just highlight what I just went over. Non-fluent aphasias, anterior injury. You'll often see, because this is associated with the motor cortex, that these are the patients that have right hemiparesis. They're more physically dependent. They're maybe not walking. Their talking is non-fluent. They may only be saying a couple words at all. and their listening is relative strength, but often also still impaired. Their comprehension tends to be better than fluent aphasia. Oh, and then before I move on from that, these are the patients too where the grammar is affected. That being able to string words together really relies on a lot of the, prepositions and determiners, things like that, where that is not really present in the non-fluent aphasias, whereas in the fluent aphasias, people are putting words together and somehow, even though they're not real words a lot of the times or not the appropriate words, it sounds like English, and that's because they often have some intact grammar. The cheat sheet for a fluent aphasia is usually posterior injury, no right hemiparesis. They're often walking around, look physically independent. They're talking as fluent, but nonsensical. And then listening and understanding tends to be a relative challenge for these patients. Next, we're going to be getting into just some examples of different types of aphasia. And I want to apologize. Some of the videos are a little bit hard to hear. And part of that is because a lot of our patients have a hard time projecting in general. We need to put a microphone in front of them. But as you'll learn later in the talk, putting any sort of added stressor or like pressure on someone's speech, like putting a microphone in front of you or a camera, can be more stress inducing. So if you can, try to turn your volume all the way up and eliminate some background noise if you can. This first, and actually all of these patients will be trying to tell the Cinderella story. They've all reviewed it before trying to retell the story. And this patient has Broca's aphasia.
Sisters, two sister and two no sisters and two no one
So you can see some of that frustration. He knows what he wants to say.
godparent. No.
He meant fairy godmother, but he said godparent. And we'll move to the next one. Here's someone who's borderline fluent. This is one of the more quiet videos. And give me a chance to cue this one up.
Once upon a time, Dad mom goes Cinderella cleans and something. Oh.
So getting a little more content out, but still somewhat empty and definitely missing some grammar. So we'll go on to some fluent aphasias. This man has transcortical sensory fluent aphasia.
Their mom had two other girls, and they were all princesses, and they thought they were going to do amazing things. And the younger one was said, "Go away. You would do whatever you want, but stay out. I take care of these my favorite little two girls." And all she went on had all this business about figuring out and doing all that stuff. she ended up being the person that everyone wanted. So then she fell off and she ran away, and everyone was looking for her. And then when they found her, they fell back in love, and they went home.
More able to get a lot more words out, a lot more empty. Without context, you might really not have any idea what he's trying to say. And I think it's important to note, a lot of times with these fluent folks, they don't recognize that they weren't being specific. They know what they want to say in their head, so and they struggle with self-monitoring, so it's hard for this gentleman to recognize that what he said wasn't very helpful. And so a lot of our therapy for patients like this are getting them to slow down and listen to themselves, be able to hear those inaccurate words coming out. So this is the hardest one to hear, unfortunately, but this is the sort of classic jargony, fluent Wernicke's aphasia, where he's saying some real words and it sounds kind of like the cadence of English, but there's a lot of mumbling and there's a lot of just real jargon, non-words being used.
Cinderella.
Brother was a drug store man there. He was a young guy, but and he worked, he trained and he returned to her. So he was friends on the call, and she worked on that truck, so a woman, a younger woman, and she would come and make things for people to stay there, and they would carry there and everything. And his story was about that thing about the guy who gets men in front. And
Oops, I'm sorry.
but then he gets those by his visible. He doesn't get visible. He has a problem, and he makes a lot of stuff of this thing in church. The thing that makes the guy the third or something, sure. And so she came to press, and she was pressed. She wasn't worked, and she always used to, but she would come first. And that woman came to that thing and made it there. And a guy came in on church and made it and gave her a soul.
So I'll pause it there. And I think we have a question. I was gonna look at that.
Yeah, I was gonna say there was actually someone had mentioned that there was a great point that you had played before
Yeah.
this. If they were wondering if, you know, they aren't understandable.
Yeah, I think there's such great questions because, and it's very nuanced. I would say, generally speaking, they're aware that they're not talking like they used to, but they, in the moment as they're talking, it's not as clear. It's like they keep having to be told that it's not making sense. I think for the most part, yes, they're aware that they're not talking like they used to, but when it comes to that fluent speech, they're just kind of on a roll. They're using gestures, so they're kind of used to their family members nodding along. Maybe their family members tend to get really, really good at reading their minds and like being meeting their needs. They're anticipating their needs. So they kind of get in this habit of not self-monitoring even more because they recognize that their loved ones are understanding them without the language. And so a lot of the treatment needs to be focused on family members providing the right kind of feedback. But so I guess my answer is kind of yes and no. They're aware, but not always. Is that helpful?
Yeah, and there was another question. Would there be more elaboration on subcortical by chance, or could you reiterate some of the characteristics a little more?
We aren't going to go into subcortical in this talk. Unfortunately, we just don't have a lot of time, and it They're not super well studied. I mean, yes, they're well studied. They exist. And I think it's important to note that, it used to be just that it was like a left-sided cortical injury that would result in aphasia, but we started, especially with TBI population, there are studies out there that just show that so many people with a traumatic brain injury are exhibiting word naming challenges and are being diagnosed with a lot of times related to those subcortical tracts. And so those subcortical aphasias aren't necessarily as cut and dry as the fluent versus non-fluent, Broca's versus Wernicke's. A lot of times they're associated with like a raspy voice, like there's a voice component. But in my experience with the subcorticals, the symptoms are sort of pick and choose. Like it's not just mostly mostly disfluent apraxia related challenges. It really does kind of get to different aspects of both fluent and non-fluent, and they can be sort of borderline. But that's probably the extent that I'm going to go into the subcorticals this time because we have a lot to get through. I hope that's all right with everyone. We do have a poll question that Tracy will bring up.
I will launch that now, and it'll be up for, I don't know, maybe a minute or however long folks can answer. You can do multiple choice on these two, as far as there are up to two. Is it at least two? I think you said, Katie.
There's at least two. I'll tell you that there are three.
So you kind of made it easy to answer that one. We're at about 50% that have answered. But I do think it's great to have those videos, even though I know it's difficult just to have the sound, like you said, you don't want to stick a microphone in their face, but I think
we're working
it's,
on trying to find a better way to have the
yeah.
better recordings for everybody.
Yeah, I think it is great though to see just how things are
Exactly.
processed. And so, we're at about 80%.
And I guess as people are answering, I will say that question that was asked, I think was directed towards, or I was assuming it was directed towards those last fluent folks. I think you could notice with the non-fluent patients that there was frustration, that they had some more awareness that they were having challenges. Spoiler alert.
I think we're about good for our poll questions. So I'm going to go ahead and close that out.
Okay. So the answers for the poll question, which of the following symptoms might you expect to see in an aphasic patient with a dense right hemiparesis? The answers that I had chosen or selected were non-fluent verbal output, difficulties with grammar, awareness of language errors. So people with a dense hemiparesis are probably going to have an anterior injury associated with non-fluent aphasias. Now, if you wanted to assume that this patient had global aphasia, they might also have poor auditory comprehension. So I maybe should not have included that in the choices. Okay, so considering that you all are connected with workers' comp, I thought it would be helpful to talk about return to work rates for people with aphasia. And unfortunately, it's not very well defined. And I think it makes sense because it's such a spectrum of challenges that people have. And it could be compounded with other brain injury symptoms aside from aphasia. And so it's really, really hard to nail down the specifics. I do have some studies to cite strictly for the stroke and TBI population, not piecing out the aphasia part. You see some very broad ranges of numbers. This Edwards study was actually of people in younger stroke working age under 65. That is a very big range, from 7 to 75% of people return to work after stroke, and then 35 to 50% of people returning to work after TBI. And I believe that was moderate to severe TBI. There is a study that was done this year, or was published this year, Duong and colleagues. They did look at stroke, employment after stroke 1 year after, and between people who had aphasia and who did not. And there was about a 25% difference. So people with a stroke who also exhibited aphasia were about 25% less likely to be back at work after a year. But I think these statistics are just really challenging to, it's challenging to make sweeping statements about a population that really has so many different presentations. I think work is being done to attempt to provide the right kinds of support for people with language disorders to get back to work. But it's really hard to study and to come up with hard data because it's such a broad spectrum of types and severity levels. Things like coordinating support and communication with employers and specific workplace accommodations are being addressed in speech therapy appropriately, but the cases are so highly individualized that it's just hard to come to definitive conclusions on, you know, who's going to be able to go back to work versus who isn't. And we're going to get a lot more into this in a minute. We'll look at a case study. This is Morris and colleagues back in 2011, and the outcomes for this study really still do ring true for people with aphasia getting back to work. And again, we'll talk about why that might be, but let's talk about some of the details of this study. Oh, and it was essentially looking at the patient himself and his reflections on the experience of going back to work. So his initials are GD. He was 45 years old at the time of his stroke. The injury was to the left parieto-occipital junction. He worked for a large insurance company with corporate finance clients. His diagnosis in the study was mild expressive and receptive aphasia. So again, those terms very common in the speech nomenclature. Based on where the injury is, you could expect that he had a fluent aphasia because that was posterior. And it does say that he struggled most with comprehension in busy, noisy environments. He was getting 2 times a week speech therapy, and he was focusing specifically on work requirements. So kind of a big red flag for me as I read this study was that he mostly chose not to tell his colleagues about his aphasia. He would instead tell people that he had problems with his hearing. And I think just in terms of having worked with aphasia for a really long time, that when people try to hide it, they're making it so much harder for themselves. They're putting added pressure on trying to be perfect, and that perfectionism does not really mesh well with an aphasia diagnosis. So what he did when he was back at work is focus on preparation. So anytime that he could, like, give a presentation, make a PowerPoint, he was really, really well prepared for that, and he could talk pretty well. But where he did struggle was in the face-to-face encounters with his coworkers, and he couldn't answer questions in the moment. He started to sort of retreat. He didn't talk with his boss very much. He really didn't think that his boss really knew how to cope with his aphasia. And ultimately, he lasted about 19 months, but he ended up being terminated from his employment. And I think the conclusions of this study are so important to make note of, and really what contributes to success or not of returning to work with aphasia. And it's so multifaceted. This patient was making gains in therapy. He was feeling confident. He was really excited to get back to work. But getting back to work in a situation where he wasn't necessarily as willing to let people know what was going on with him, and so that his workplace didn't even necessarily have a chance to accommodate him, was probably not a great plan. The nature of work may have a strong bearing on success, as will the ability and the willingness of the employer to engage in the process. So important, the people that the patient is interacting with really need to understand how to support. I think when you talk about the nature of the work having a strong bearing on success, you can use the example of, say, a chef trying to get back to work after he's lost his sense of taste and smell. I heard stories after COVID of chefs who really couldn't work because they couldn't test the quality of their work. Similar, if someone's job absolutely includes a lot of communication, needing to follow directions, needing to, speak on the fly with a lot of people, fast paced, that is likely not a job that is going to be suitable for someone even with a mild aphasia to get back to work, because they're not going to be able to meet their prior standards. Let's see. Oh, and then partnership with a person and constant review of goals and management for the speech therapist. That were really related to back to work. But I don't think that it was necessarily contextualized. And I think if I had been the clinician here, I think I would have really explored what it would have been like to feel comfortable enough to share the diagnosis with their colleagues, because that would be setting themselves up for more success in the workplace. So because we need to be so careful with aligning these goals and making sure expectations are realistic, I would say most aphasia therapy shouldn't set out right from the beginning with the goal in mind of returning to work. That will make the progress feel really slow, and like the only measure of success is getting back to work. And so you can do a lot of quality of life goals that are kind of feeding into what does it take to be back at work. So when you look at quality of life, when it comes to people with aphasia, it's pretty impacted. This study by Lam and Wadkus showed that people with aphasia exhibited the largest negative influence on quality of life measures, and that was followed by cancer and Alzheimer's disease. So you can imagine communication arises in just about everything we do in life, and so they're just constantly being made aware of their challenges, even in situations that you would think should be low pressure. Another study looked at the consequences of aphasia, and as you might imagine, things like social isolation, exclusion, loss of autonomy, stigmatization. Can't tell you how many of my patients really think people think they're stupid because the way that we interact, if you don't respond quickly, if you can't get the words out, there's sometimes a snap judgment, and people with aphasia really feel that. So again, it results in such isolation and such sadness. There's a high correlation of depression and aphasia. I'm going to shift gears briefly here, and it'll make sense in a minute, to talk about the autonomic nervous system. And that entails the parasympathetic nervous system and the sympathetic nervous system. The activation of both of those systems is highly related to your sense of safety and comfort. So parasympathetic nervous system response associated with rest and digest, healing, social engagement, those things are more able to happen when you have a good sense of safety and you feel comfortable in your skin. Contrastingly, sympathetic nervous system response is associated with fight, flight, or freeze, less access to conscious thinking. It's more reactive. These responses are contextual. They're usually related to the environment. Something scary is chasing you. But as we've evolved, scary things don't have to mean that we have to run and that our blood is being taken away from our brain and sent down into our limbs. Stress can be, a kid having to take a test or public speaking. Those kinds of things activate the same type of nervous system response that give us less access to conscious thinking. So again, looking at that environment and the context that influences our autonomic nervous system responses, we can look back to our case study. GD went back to work, thinking that he was pretty well prepared. He had made great gains in therapy. He was feeling pretty confident. But again, like I said, it can be so hard to recognize how much we're relying on language all the time. It wasn't just the presentations that he was feeling really good about, the PowerPoint slides, but in the more demanding, like actual job related parts of his job, he was doing okay at. But actually communicating with his team was sort of debilitating for him. And we see this so often with aphasia. Interacting with anyone, anytime can have a sympathetic nervous system response for people with aphasia, and that can kind of put them in a constant state, heightened state of nervous system activation. So just to look at what are speech therapists looking at in terms of goals to restore language and to help people with communication. Restoration, we would kind of argue that being able to restore those neural systems would probably require something more intensive. Speech therapists are also looking for strengthening of some of the less affected areas of speech. Compensatory strategies, very important for both restoration and just compensation, when we maybe wouldn't expect that the language systems would improve. And very, very important would be communication partner training. So making sure that family knows how to support the patient's comprehension in order to build confidence for communication in general. That might start just in the home with people that they trust, then bringing in friends and others who can slow things down and be really present. Because in order to be able to then participate in everyday situations with strangers, that they have to be very well established in these strategies before that will be possible. Okay. So some overarching concepts in any of those ways of treating: patience and presence, expecting more and supporting more, and defining communication expectations for the patient and for family members. I'm not going to get super detailed with this because we have so much to cover, but we need to be present with the patient. Anytime that we are sort of just going about the conversation naturally, ends up making the patient feel rushed, because they almost always need a slower pace to be able to comprehend and to be able to jump in and say what they want to say. They need more time. It will take the patient with aphasia out of that fight, flight, freeze response, give them access to higher level cognitive functioning, better availability of words. As a speech therapist, we need to learn to expect more when they are supported with that presence, and that when their nervous system is calm. So being able to, within a session, give them the time that they need and really let them feel what that is like, let them feel the success of that. So you're always creating opportunities for them to communicate and not just filling in the blanks for them. And I've already just talked about that. Oh, sorry. And then defining communication expectations with the patient and or family members. So lots of homework, making sure that these strategies are something that are being addressed at home, and that the family is able to provide support with as well. But I think takeaway message here is treatment and practice need to include interactions with other people. That's essentially what I've been getting at all throughout these last several slides, is that if you're just going through flashcards or doing worksheets or spending all your time on an app, and we have patients with aphasia want to work so hard most of the time. They want their language to be better, and you give them something to do and they will do it. And I think it certainly can help to do any of those home practice things, whether it's pen and paper tasks or apps. But if you aren't also including real life sort of situations that are a back and forth exchange, which is what communication is, then you're really missing out, because the patients then don't have the opportunity to recognize, like, what do I do in this moment where I'm feeling pressure from somebody to give a response and I don't know what to say. So they sort of go out of their body and feel really, really overwhelmed and then shut down. So the therapy needs to be very focused on the specific challenges that the patient's having, and then also incorporate what is it like to use strategies to access words in a real life situation. This kind of says the same thing. Improving your language just by yourself doesn't translate to improved language and conversation. So like I said, apps, there are tons of apps out there. It's actually, there more and more are being developed. And I don't think they're a bad thing. I think they're a nice supplement, but I don't think we can expect them to be the only thing. I have a lot of people show up to my intensive aphasia program that are really invested in the apps. And I don't say not to use them, but if it's taking the place of actually having meaningful interactions, then we probably need to find a better balance. Okay. What the literature says. So we've talked a lot about what should be included in any aphasia therapy. And now I want to talk more specifically about making what we would hope could be permanent neural changes, because that's really what we're working towards. And there's a lot of overlap with motor learning principles, which have been well studied. So if we're looking at intensity, what a study back in 2003, and it has been replicated, is that about 8.8 hours per week, patients were able to maintain gains, and they were able to make progress. And so that's kind of what we would consider like the gold standard for an intensive program, is that like around 9 hours a week. Specificity, work on what, oops, sorry. There.
You can go ahead. It's okay.
Sorry. In addition to a lot of, like, sorry. You're practicing a lot intensively, but it can't just be practicing like every single thing that is hard. You need to be really specific about what you want to get better. You aren't working on, 12 different goals during an intensive program. You focus on one or two really specific things to sort of get yourself to the next level. Timing, this is a question we get a lot. Early is good for the most part. You're getting people to address motor learning principles. If you don't use it, you lose it. So we don't want to run into learned non-use. And by catching people early, we're taking advantage of plasticity mechanisms to help facilitate behavioral change. And we want to also catch people before that learned non-use sets in. In motor recovery, if we've got somebody who's right hemiparetic and they're not using their right arm, but they can use it a little bit, but because it's not as good, they start really favoring the left. Then that right arm starts to even get worse with the non-use. Same thing happens with language, is that if there's some preserved language, but they've got family members that are absolutely able to read their minds, then they don't end up doing the hard thing of challenging themselves to say what they want to say. They just kind of retreat. So we want to avoid that. We want to make sure that we're treating patients early enough so that they don't get into those habits. That being said, we also don't, in an intensive program, we don't want to waste valuable resources treating something that was going to improve on its own. So we don't necessarily want to be doing an intensive aphasia program more earlier than 6 months post. We certainly make exceptions, but we want to give time for that spontaneous recovery, and make good use of everyone's time. And then also just accessibility, making sure that the treatment is easy to get to and available. So more on intensive aphasia therapy. That was kind of the motor learning principles. It looks like frequent targeted sessions to help people build communication skills more quickly than traditional therapy. It does require cognitive endurance and drive, self-motivation, and the key here, the helpful thing is that when gains are made more quickly, so they're seeing it, within a few week period, they recognize that they're making progress, and then you can start to really build on that competence. And then they'll have more of a tendency to continue talking and using those strategies. Other advantages to intensive aphasia therapy. Because of the psychological challenges associated with aphasia, longer treatment sessions allow for greater trust building with the clinician. And as we talked about before, with the nervous system responses, being able to kind of have that time and that space is really, really important to be able to talk about anticipating how would you build this trust? How would you build this, as a part of your aphasia recovery? How does this become more of a conscious part of that in your community? And then the patience is key. So if we're talking about trying to give patients, our clients, as much time as possible to respond and not make them feel rushed, a 50-minute treatment session kind of inherently can have an underlying time pressure. But if a patient is being seen in an intensive program, there's a lot more opportunity to give them the time they need and actually experience the success that the patients can help foster. Okay, second poll question. Oh my gosh, we're getting down to the wire here.
I know. I was like, we got to get moving.
Yeah. But essentially, we're getting through the meat of this, and then the next part is going to just be me telling about our program.
Yeah. And I'm going to go ahead and launch the second poll
Sure.
question.
Yep.
And it's a true or false. But there are some great comments in the question and answer too, Katie.
Oh, sure.
That a lot of folks are asking about maybe a list of the apps for aphasia. I'm wondering if you might be able to put some of those together and send them to me. And when we send our follow-up email with the
Sure.
recording, I can include those
Okay.
for
Yeah,
folks.
I can do that. I full disclosure, I don't tend to use a ton of like self-directed apps. I do have some apps that we use kind of as part of therapy, but yeah, I can certainly put together a list.
Okay. And it looks like we are pretty good with our poll. Everybody's participated
Great.
for the most part. A few more people trickling in, but we could probably at least go to your next slide and
Yep.
give them the answer.
Sure. Oh, what is happening? So the answer is true, but with the big caveat of that it would need to be supplemented with other communication as well. And not just kind of that self-directed on your own, no talking kind of app work. Okay, so yes, we at Craig Hospital do have our own intensive aphasia therapy program, lovingly called CHAT, our acronym, Craig Hospital Aphasia Therapy. And let me just tell you about it a little bit. But if you have to jump off, you can go to our website and there's lots of information there. But I hope it's just that you're aware that we do have a great program here in Colorado. Participants come for 3 weeks. It's an outpatient program. It's about 4 to 5 hours a day, Monday through Friday. 3 of those hours each day, or should average to 3 hours a day of one-on-one speech therapy with the same therapist, the same 2 therapists every day. And then we would supplement those with group music, AAC, assistive technology, yoga, and family training. So it's usually a total of about 20 hours, a total of 60 hours in the 3 weeks. Very protocol driven, with a focus on verbal output. A lot of those intensive aphasia programs are looking at different modalities of language. This program in particular looks at how do we get people talking better? We've been open since 2017. We have now offered 106 3-week programs in person, mostly in person, and some telehealth when COVID happened, but we, on a case-by-case basis, can offer some telehealth programs. We see patients with TBI and stroke, and sometimes with tumors. We do not see progressive diseases like dementia or primary progressive aphasia. We treat a range of ages and severity levels. I think this kind of treatment, our program in particular, lends itself best to more of the non-fluent folks, but we certainly do treat patients with fluent aphasias. Good candidates, like I just said, TBI, stroke, or tumor. They need to have cognitive endurance. People usually go home each day and take a nap. It's very challenging work. They need to have basic comprehension skills, so following simple commands that are not contextualized, answering simple yes/no questions. They need to they need to be using a few words appropriately and consistently. So it would be hard to come to this program really having nothing to work with. So we typically make sure that they have at least some things that they're able to say with purpose. They need to be self-motivated. We cannot trick people into doing this much therapy at once. It is very challenging. And so they need to be the ones and not the family members encouraging them to come to a program like this. And they have to feel that their quality of life has been significantly affected by aphasia for the same reason.
Hey, Katie, really quick.
Yes.
What is I know it like within our hospital, we treat 15 and older. Is there an age limit with
Yeah,
chat?
that's probably our limit. I think we actually have a 16-year-old coming in the next couple of months. I don't think we would go below 15, but that would be something that we could, definitely look at. Our average age is kind of in their 40s probably.
Great, thanks.
So like I said, one-on-one therapy is the cornerstone of what we're doing in the chat program, but we also have those supplemental things. We get a lot of great feedback in the supplemental. The chat group is super, super beneficial. People just being able to connect with other people going through something similar. Just people with aphasia needing to hear that someone else understands like fully what they're going through is really therapeutic. I'll just skip over this. This is what a typical week looks like. So averaging about 4.5 hours a day. Our outcomes, we typically see improvements in standardized testing. So the Boston Naming Test, Western Aphasia Battery, narratives, so storytelling. We do a lot of transcriptions of people telling us stories, and usually pretty consistently we see people improving by at least 10%. So getting to a level where they are having more helpful, accurate output in storytelling. And this is they're getting better in both what we work on and the vocabulary that we work on in the program. And families are constantly talking about, well, they just said this out of the blue. So it's generalizing to being able to access other words as well. Patient and family rating scales for communication confidence and accuracy improve. The only time that we see a decline is a lot of times for those fluent folks who don't have a lot of insight and awareness for their challenges. So initially they might think they're speaking better than they do. And then the program helps them be a little bit more aware of the reality. Oh, and then we already talked about that part. There are studies that show that people are maintaining their gains. So this was 8 to 30 months after intervention, and people were maintaining the gains that they made in this intensive language action therapy, which is what our program is based in. I want to give just a quick case example. This is someone who came through our program. He was 2.5 years after his stroke, and he barely was able to say anything. He was speaking about 10% of what came out of his mouth was accurate. He had a 3 out of 10 communication confidence reading, and I think that was only at a 3 because he had a relative strength in writing and typing, so he could text pretty well. he usually relied on gesturing, pointing, and writing. I'm going to give you a quick sample of how he was of how he was talking. This is how he got his dog.
To a dog. I want a dog, and I was driving to here, there, for the car, like for months.
So you can kind of read through that. I'm not going to do the whole thing because we don't have time, but this is what, so a lot more was accurate, and you can kind of see he's just more relaxed.
Okay. I want a dog for years, and after school, I want to a dog right back.
Oh.
I have a pain in the money.
And I'm going to pause this. I think I was misleading there. He went through 2 programs with us, one in December and one in June. Initially, he was 10% accurate, and then this is actually his second intake. So he had even improved more after that first program. So let's get to the end. This is his artwork. He's an amazing artist. His mom gave us some feedback after the program. I just spent the best 10 days with Michael that I've had since his stroke. His ability to understand and what he was hearing was amazing as well. This program has been a lifeline for him. I have all his outcome measures, but I don't know if that will be as important as I think some of the patient, feel good. Michael said, I thought my speech was lost forever. He typed this. He wasn't able to say this super fluently, but this is what he thought of the chat program. I communicated through charades or phone apps, or worse, I skipped communication. Today, I'm talking with my family and friends, having long conversations, and they can understand me now. The chat program is life-changing and life-saving. Let's get to the poll question, because I know that we're almost out of time. Sorry. And then if people want to stay and have any questions, I can probably do that. Sorry to rush through the end there.
I just launched the
people
poll.
that are great. Who are people that are good referrals to an intensive aphasia program? What kind of qualities do they demonstrate?
There was also a question about medications. Are there any additional medications that either play a role or can help with aphasia?
That's a good question. I think that I do know several people with aphasia that are on antidepressants that can help, helping with mood can help people do the hard work in aphasia therapy that can sort of get them over the hump.
Kind of make them feel more comfortable and
make them feel,
yeah.
just because that can be so debilitating when you can start to feel hopeless. And I think I do see a lot of people with aphasia on antidepressants. In the program, that's not something that we recommend or encourage, but I do know that there have been studies happening for things that happen directly with language, but I don't think that there are, I say to my patients all the time, I wish I had a magic pill I could give you. I wish there was something that just activated these centers of your brain. And to my knowledge, that's not really out there.
Yeah.
And
I
then
think sorry, I was gonna say I think we have about everybody in, so I can go ahead and in that poll.
Okay. And the answer would be D and E. So people who are driven to work on talking and people with aphasia who struggle to find the right word. People with memory impairments are not going to do well in an intensive program. They need to be able to maintain those gains and remember what we've been working on from day to day. You need to have some decent comprehension, otherwise you don't get the buy-in for working this hard. And if a spouse just thinks that they need it, the patient is not going to be motivated to work this hard. Oh my gosh, I'm so sorry.
You have lots of great stuff to say. Don't be sorry. if there are any additional questions. Otherwise, what I can do is go through the Q&A that we have and send those over to you, Katie. And like I said, I can, when we send out our follow-up email, I think some of you may be dropping off, but
Yeah.
you will be receiving an email directly from CEU Institute. So it won't be coming from Craig and necessarily for the continuing education. So keep an eye on that. Sometimes it may go in the junk folder. That usually will come to you within the next week for any continuing education, licensure information. And then at Craig, we will also send you a follow-up with the attachment of the information provided today, answering these questions, and a link to the recording as well. So if there are any other additional questions, I can get those over to you, Katie, and we can answer them. But
Great.
thank you everyone for your time. And thank you, Katie. Really appreciate you and everything you guys do over at
Thanks.
chat.
Oh, yeah. And I forgot to put this on with my contact information if anybody wants it.
Perfect.
And then I also have references, and that should be sent with the slides.
That'll be in the slides as well. And then we'll work on getting those apps and all that good stuff. So thank you everyone again. Really appreciate it. Have a great rest of your day, and we'll see you in 2025, hopefully.
Awesome. Thank you.
Thank you.
Bye-bye.